So health literacy really relates to the personal skills and characteristics of people and their ability to be able to find, understand, appraise and use health information to make good decisions about health for themselves and for their family. It's not really just about the individual though, it's important to consider health literacy in terms of health services and health organisations, and we've kind of coined a term called health literacy responsiveness. Which means that services are able to support and provide resources to people to be able to make those decisions about their health. It's much more than just reading or writing or numeracy skills. It's a very broad concept now. It relates to things like the way that people engage with healthcare providers, how they navigate healthcare services, their social support or community supports for health and so on. So there is plenty of evidence now that having lower health literacy is associated with poorer health outcomes, greater mortality, inappropriate use of health services, less use of preventive health services, poorer self-management skills for people with long-term conditions and so on. Ophelia is actually an approach or a process for improving health outcomes, and the basis of Ophelia is a multi-dimensional tool called the Health Literacy Questionnaire. And it measures health literacy across 9 different scales or domains or different areas of health literacy, because then it gives us real data. It gives us real information about what people need. I think, and because of that, it then gives us a mechanism for achieving change. It gives us a way in. It tells us where people really need help or where they're stronger, and we can use those stronger points to intervene. It's a locally based approach. So data is collected using the Health Literacy Questionnaire and some other sort of needs assessment data from people in the local community. So it's their data, it's their information, and it's their needs that are being assessed using the Health Literacy Questionnaire. So if there were a lot of people from diverse cultural backgrounds or a particular demographic group in a local setting, because it's based on their data, it's based on their needs, and it's using the knowledge of the practitioners and the healthcare workers that work with these people all the time, it can certainly be tailored to just about any context. So we're using it in Victoria and Australia across 9 different healthcare organisations. So these are ranging from community health centres to community nursing services to municipal councils. It's also being used in cancer screening and also in cancer treatment in Victoria, and in cardiac populations to look at who does and doesn't go to secondary prevention services. It's also being used in New Zealand amongst Maori populations, and it's being used in Indonesia. We're about to go over next month and start looking at a process for people with TB who are not taking their treatment to completion. It's also been used in South Africa in a shanty town amongst a community-based organisation for emergency first aid responders. So across, and in Thailand it's been used in several different places, Myanmar, and hopefully in India soon as well. So I think that kind of demonstrates the flexibility of the approach, that it can be used in different settings and contexts. So I think organisations benefit because they really understand then what their clients need. It can be used even at a kind of quality, as a quality measure. So if lots of clients in an organisation are saying, well, actually I don't really trust my healthcare provider, or I don't feel that I can ask them questions, or I can't navigate, I don't understand what services this organisation offers me and what I'm entitled to, and the information I get doesn't mean anything to me. From an organisational perspective, that's, hey, you know, there's all this sort of stuff that we've got to change now, because this is not we're not meeting the needs of our clients. Whatever intervention that practitioners come up with doesn't need to be massive. It doesn't need to be expensive and hugely resourced. It can be a small intervention and it can make such a difference. So some tiny little interventions at one of our services in Victoria, for example, around engaging patients in better conversations about their learning styles and their education needs. Very, very small intervention. I did a focus group with them last week. They came in, experienced clinicians, 10 years experience, coming in saying, this has changed my practice. Really raising their awareness of what their patients and clients need. So I think that just the fact that people might worry that, oh, this is going to be a really expensive process, we need to put lots of money into developing these interventions, actually doesn't take a lot of effort to make a change, because I think it is based on what people need.